One of the most important things in any refractive surgery today is how you manage your dry eye. And this is something which is important because I'm not going into the basics of the whole dry eye and this gamut of stuff which will be discussed over time, but we'll just keep it very simple. These are my financial interests. And again, the most important structure in outcome when you see the quality of vision is your tear film. And tear film has various things involved in it, and most important thing is the role of immunopathogenesis. And a lot of these molecules will be discussed also about its impact in your dry eye treatment. So if you, this is a nice paper by Dr. Sharon and Dr. Rishi and Edwin out here about algorithmic approach of managing dry eye, and which explains a lot, and we will share this paper on the group also. But we have to understand that there are a lot of therapies now for dry eye. When you look at the LipiFlow, the iLight, the EI, and question always kept asked is how do they actually work, and what is the mechanism of work? And this is very important because we're using a lot of these dry eye therapies without really looking at how they actually work on the whole structure of immunopathogenesis of the eye. So this talk is all about looking at how they actually work and at what pathology work. So we have the IPL from the iLight group. We have the EI. It's in India. It's a French one, but it's distributed by the Monish, and My Healthscape is looking at this. There's a new one called InMode, which uses radio frequency and vector pulsation from Zeiss. This is how it's classified. So when you look at light-based therapies, EI looks at, it uses a, pulse, the photochromatic xenon light. The mechanism is very important. Everybody says when I use any of these therapies, it works, but we don't know how it works because very little is known about it. Each company, hidden somewhere, has their own way of how it works. EI works on stimulating some meibomian nerves of the meibomian glands. There are photomodulation from iLight also out here. So these companies have, when you look at photomodulation, they work on the vasculature. That's why they've been used a lot in dermatology for acne, rosaires, and other things. And this is iLight. This is EI on this side, and this is an iLight which works on the photomodulation aspect of it. So these therapies have a tremendous impact on how they improve the tear film dynamics, improvement in your dry eye parameters. They don't do much on your meibomian glands, but they improve the quality of your tear film. LipiFlow, again, there's a booth here. We'll see if we can bring this for a demo. So what it does, it has a constant temperature on the lids, and it gives you a nice massage on your lids to improve the tear to the meibomian glands. And it is known to act on certain strong molecular pathways here. And this is just a video which shows this, how it works and how you put that contact lens into it and how it can work. And this results, again, for all of them, we have all the three technologies, has been quite good. My LipiFlow is close to, I got it at 2007. And today it's close to 16, 17 years of 2007 or 8. It was of using this and iLight and EI. But there's always a big challenge about what is it actually doing to improve the quality of vision. And this is again a different new technology which uses a radio frequency along with intense pulse light. So it combines both. It's a dermatological tool. They're also coming very into the market. There's something which is quite exciting is called the MeiboFlow. The MeiboFlow is a new one, but this is something which I feel has got a huge impact in your dry eye clinic because there is not much of recurring cost. And It does work well because it uses the gel and it uses this kind of thermal heating pad, which kind of had to do it manually. But the results we have been using for the last 3 years, 3.5, 4 years, the results have been as good as you would see with any of the other procedures. So that means every machine has its own uniqueness. And the good thing about this is it's a small footprint, very hardly, it doesn't take space. And the most important thing is that it does have its role in having no extra recurring cost for you in your practice. And this is the just like your ILite, it's just 0, 15, and 30. And this I use it in a lot of my general OPD and those kind of patients who just come to you. So you don't have to charge them more. It's very fast and it works much better to me in my practice. And it's a timing and it's a preheated device up to around 42 degrees, and outer skin, and hardly any light or anything which bothers us, which will have an impact on the skin burns or anything like that. We don't see it in them, and this has its own molecule pathways which has its role. So these are all some of the quality of vision. You can see the tear film which does it works on it. So when you look at these things, this is how you evaluate. Of course, these are some imaging modalities when you do more, when you want to understand more, when you want to dwell more deeper, like what we just mentioned about your confocals and other things. So this is an era of personalized care, and one of the major areas of personalized care is understanding the role of biomarkers and all that things which you would ignore when you were a medical student, or when you are doing those, you just not bother because you think it's nothing related to you or your practice. But as we move on, I feel these molecules have more important role in understanding what it does, because these molecules are the ones which are it's a pillar stone of every symptoms, every outcomes, everything what you see. We all know about the most famous one, the MMP9s, but there are more than 21 or 30 or more than that in the family of MMP9s. Interleukin 6 became very famous during COVID. The what you call cytokine storm of COVID was people who had the lung-related change, if you remember, were all driven by IL-6. People were trying to see if they can block IL-6 completely. If you block IL-6, we will not be surviving, because IL-6 is necessary for the health of the eye. But when it become a rogue, when it become a terrorist, then it can completely offset everything. It is necessary for angiogenesis. Without IL-6, blood vessels cannot grow. Everything will stop. The ICAM1, the intracellular molecular one, is a T cell. I showed you a beautiful T cell in one of the confocal microscopy, and T cell mediated responses. All of them have a dry eye. Tumor necrosis factor, a big culprit in apoptosis. That means it is responsible for death of any cells. More of tumor necrosis factor. The good amount of TNF maintains your health, body, cancers, it prevents everything. More of this is death. So that is something which is very important. And where is it important is scarring. If you have a lot of TNF in your system, you can be genetically having more of it, and you have a tougher dissection of your lenticule. Next day morning, that particular lenticule will have more of scarring or patchy areas of scarring, because you are driven by, your body has more of those things. And PRK, we published, and PRK haze is completely driven by the TNF. There are other friendly ones, not so friendly ones. VEGF is a very important factor. VEGF is angiogenesis. It's there in tears. When you talk about VEGF, everybody talks about retina, but we need a good amount of VEGF in your ocular surface. More of VEGF causes conjunctival disorders, endothelial survivals. Interleukin-1 beta is persistent pain, is one of them, lid-related squamous metaplasias. And interleukin-17A is where, when you have those epithelium being very vague, which is multiply changed, and you have patient coming to you with persistent epithelial defects. You have this loose epithelium, and you don't know what to do. And these are all published, multiple publications from every pair in the body, not just the eye. Very few in the eye because it's very, very difficult to work on it all the time. So we looked at these factors and looked at where they have a role in it. And you can see that they have a big prognostic role in how you heal. And this again comes to the biology of lenticules, so biology of healing, biology of, you have an important role in how they heal. And we have just, there is a machine outside. If you want to get your tears analyzed, you can do it. This is the first time we are keeping that machine in a clinic. I've been speaking about it for the last 14 years. And it's a big day when we have actually, it is going to come to the clinic where you can use it in your clinic, and it's just outside there. You can take your Shermer strip, put it into this, the tears are leached out, the proteins are leached out from your Shermer strip with the buffer. You put it in, and in 90 minutes, by the time you go back, your patient finishes his dilatation, your report is ready. And what report do we get? And this again will be played tomorrow. So, okay, this is, so this is the flow. This used to be the flow in the past. Now we can store it also and do it later, or you can do it immediately also. I mean, that depends on. And based on this, there are a lot of you can choose the type of lubricants. You can choose the type of procedures. You can choose different types of medications because each and every drug has its own action. For example, I was told, and I've been aware that the Micro and Ajanta and many other companies in India are bringing out the Liftigrast. The Liftigrast has its role in ICAM1 and IL-6. If your patient has a lot of these markers, each one, every different thing works on a particular pathways. Why? And we are looking at fluid markers in undergoing intraocular surgeries, and this is what a cataract patient would be having. And this is what a cataract patient has without your knowledge. You can see that. That's why, many of your cataract patients have itching. You somehow you avoid everything because you put steroid for 6, 8 weeks or 12 weeks. But imagine if you're not putting steroids for your cataract patient, every single person would have come to you complaining that he has pain, itching. But still somebody comes to you with all this because they must have had such a high level of these markers. Sometimes you do cataract surgeries, they have epithelial punctate erosions, they complain of, you put in, Nebenac, one of these drugs, they are not happy because you have very high level of IL-17A and you have MMP9s, TNF-alphas. If you have a high level of TNF-alpha and operate a PRK on him or do a cross-linking on him, he's definitely going to have an excessive flattening or excessive change. The answer to every single thing happening in your surgery lies in the biology. Of course, skill and other things, I'm just not discounting that aspect, but biology plays a very important role in it. So when you look at these machines, they have a tremendous capacity to reverse this immunology. And this is all from the published work that, you can see so many we use many more factors. All these factors are nociception. Nociception is that it gets irritated. Anything which makes you feel irritated is excessive nociception. And this nociception factors leads to dry eye. And you can see that this is a very important paper from the eyelight perspective. This is what, it reduces these markers specifically. That means it reduces markers of itching, reduces marker of epithelial regulation, it reduces it increases angiogenesis and helps in healing. So what is interesting is, for unknown to biology, every single machine has a unique way of reducing some markers, and this is published in Cornea. And photomodulation reduces MMP9 activities, IL-6, both responsible for your itch factors. Both are responsible for, in keratoconus, all of them have a thing. Ectasia, they have a huge role in ectasias. They have a huge role in building collagen. Tomorrow, if I'm operating on a patient on whom I'm suspicious that my case might be, my cornea is weak, if I reduce IL-16, IL-17, I can build my collagen. Because collagen, they are extremely excess of them have a change, they cleave the collagen, they damage the collagen. And we looked at the other vector pulsation. This is from for the J&J's LipiFlow. Look at this. They have a separate one, IL-6, IL-17, IL-1A, and so many other factors. So that is one of the reasons, if you have access to iLight or LipiFlow or MyboFlow, and I think combine both of them, because when you combine both, people say, I did a LipiFlow, it didn't work well. I did an iLight, it didn't work well. This is a very good answer why it doesn't work well sometimes, is because your pathways of how it works, for example, the pathways of ocular surface pain, healing, inflammation may be completely driven by it. This might be modulated by your EI, iLight, or your MyboFlow. But what is important is the vector pulsation works on a completely different pathways. So if you have two pathways and your one machine may not be touching upon it, that may be the one of the reasons why it doesn't work. People have said, I've done LipiFlow 20 times, it has never worked. Or somebody said, I've done iLight 24 times, it's never worked. It's because you are touching a wrong pathway. If your molecular pathway is driven by interleukin 1 or 1A, that is not going to be affected by your iLight. So that means that not working doesn't mean that machine is not working. Your biology of pathway is completely different. The genetics of how your molecules are secreted is completely different. So that is one very important reason why many times combination therapy of two things work well, because you're combining two different pathways. You can combine MyboFlow with the iLight or this one. So this combination really has an important role. Let's look at some clinical scenarios here. This is a pre-LASIK patient. Remember what I said, angry epithelium hides an angry inflammation. This is a take-home point. This is an angry epithelium, according to me. There is anger in it. What it hides is an angry, this is a report what we get for every single patient. But what it hides is, it hides also a lot of inflammatory cells. This is a very good work done by Natasha Pauja, who's here in the BJO, part of her PhD. What she said is, patients who have a chronic level of inflammation develop ectasias. They don't allow the nerves to grow. This is where the lenticule procedures have a lead, because when you bypass the nerves, you bypass the immunology. When you bypass immunology, this is where it's going to have an impact. And these profile of molecules hides T cells. The eye is filled with T cells, T lymphocytes, and dendritic cells. You do any surgery on him, he may not come to you repeatedly, but he is going to bother you because his life is going to be bothered. So these patients need treatments, and when you see them, you can see that immediately within the first 2 weeks, you completely drop the inflammation, and that's when you do your surgery. That's when you get and these patients are the one who would have excessive edema, slow healing, epithelial remodeling. And this is again one more patient which shows, look at the ICAP level, everything has dropped down. Many times we blindly give a treatment, assuming that some treatment may work for every patient. For example, if this patient was treated on, say, X drug like T-cell modulator like liftigras, the patient will not be, he will not recover because his ICAM1 is completely normal. His problem is IL-6 and all those factors. This is why many drugs don't work, because it is not targeting what is supposed to target. It has to target these, not the one. So it is future, maybe 5 years, 6 years down the line, you will probably have this kind of reports in your practice. The diabetologist will not give insulin looking at the insulin level, but we are treating inflammatory molecules without looking at what molecules we have. We have some excellent drugs now with newer molecules of Sequa, which is a faster acting, or the Restasis, or many other molecules which do have, but we have to understand it has a huge role in looking at the markers. For example, this is again a post-operative case, again come back to a surgery and look at his, again an angry looking epithelium. And you can see that these patients. And coming back to the last case, which is a post-operative, uh, his T-BUT is good, but this is a typical pain without stain. That means your T-BUT is good, Shermas is good, but your tear film is breaking down very fast. The tear film is causing a scatter. This is from the tear film itself. And these are all the other functions out here. And again, the hidden a lot of unwanted cells out there. And this is a classic case where again you have to do a combination or at least treat them very aggressively in this, because these patients cannot, all these markers cannot be treated by one single drug. You have to have a combination of drugs with LipiFlow, with addition of MiboFlow or iLight. I know it's tough financially. I'm just talking from an academic point of view. I mean, finances is a completely different ball game. But from an academic point of view, this is how the biology is, and there is no way you can change it. And you can see that how it changes over time. So in conclusion, I think there is a huge scope for any light-based or vector-based therapies in this world today, because we are ignoring them both in cataract, refractive surgeries, and even lenticule procedures. Your outcome of your wow, which a lot of people are talking about, the day 1 wow or day 2 wow, everything depends on how healthy is your ocular surface. If your eye is not healthy, you have a high level of TNF and all these factors, you will always end up in a very poor outcomes. So along with all the other things we consider in our practice, these things makes you much more safer as a surgeon and much more personalized as a surgeon. Thank you.